Welcome back to Health Policy Off Script. I am Matthew Hart. We've heard it before and we'll hear it again. Freedom, courage, and bravery to make change. What's the plan when it comes to our healthcare workforce? What are the issues? What are not the issues? We'll dive into the waters head first and explore a little deeper than we normally go. To start our conversation and introduce our guest, Arthur Sweetman from McMaster University, will be Ivy Bourgeault and Dale McMurchy. I'll now hand over the mic to Ivy. Enjoy.
Thank you, Matt. And I'm really pleased to have as our guest on Health Policy Off Script, Professor Arthur Sweetman, a colleague of mine. He's a professor of economics at McMaster University. He's also the director of the Health Policy PhD program there. He holds the Ontario Research Chair in Health Human Resources. He's the co-lead of Health Workforce Data Theme at the Canadian Health Workforce Network. And he sat with me and many others on the Canadian Academy of Health Sciences review panel on Canada's health workforce, which produced an important report in 2024. So welcome, Arthur.
Thank you very much for having me.
So let's dive right into it. I know we both know a lot about the health workforce. I think it's important for our audience to just understand a little bit of background about how the health workforce is developed and deployed. So education and training pathways for different health workers and how they are deployed into practice and so that we can access. So it's kind of like a health workforce 101.
Well, why don't we start with an even bigger picture, because the health workforce is a little bit different than most sector workforces you might think about, like say construction or auto workers or something. And there's two big groups. The biggest group is in the public sector, and that makes them quite different because they are providing what many people think of as personal services, but they're largely in the public sector. But then there's a second group that are largely in the private sector. And it's important to make a distinction in terms of training, remuneration, the nature of service delivery between those two. So on the public side, physicians, almost all or virtually all physicians in Canada are in the public sector. Then there's nurses, again, the vast majority in the public sector. You can keep on going. There's a large number of medical laboratory technologists, mostly in the public sector. On the other side, you have ones that are primarily in the private sector, although there's been some recent transitions. So dentists, primarily in the private sector, some recent policy innovations that are putting a little bit of public sector in there. Same thing with most physiotherapy, not all physiotherapy, most physiotherapy is in the private sector. And it makes a substantial difference to the workforce, the training of the workforce, but also the deployment of the workforce, whether they're in the private or the public sector. It makes an enormous difference. Most people, when they think about healthcare, think about physicians. They are unique. Not just in Canada, but in many parts of the world. So in Canada, we are a little bit different, Canada and the US both, a little bit different than many European countries. Well, most people in Canada would do an undergraduate degree and perhaps even a graduate degree before going to medical school. And competition for medical school is fierce. If Canadians only wanted to go to medical school now, if only willing to do it, then we wouldn't have these shortages. But in fact, it's the other way around. Medical school is probably the only specialty or the only field at universities where provincial governments dictate the number of seats. So medical school is a thoroughly controlled access in terms of the domestic medical training. And similarly, there's substantial controls on the immigration pathways as well. It is a very regulated profession.
But I think that there are, particularly in the public institutions, like for physiotherapy, occupational therapy, nursing programs, I think that the government controls those numbers to a certain extent.
Not to the same degree. And the further you get away from the public sector, the less. So the government has some influence on nursing, but it doesn't dictate nursing numbers the way it dictates medical school numbers.
Okay. Well, it's competitive to get into some of those other schools as well, like the physiotherapy, occupational therapy, midwifery programs. Yeah. So
not taking away the competition that happens in lots of in-demand programs. But so typically it's a second or third degree. Medical school lasts typically 4 years. There are a couple of exceptions in Canada where it's a little bit shorter, and followed by a residency program. So a residency program you can think of as an apprenticeship. there's a very complex matching process between what physicians apply to of specialties and what they're accepted into. And in Canada, we call it CARMS, which is a residency matching system, a Canadian residency matching system. And the CARMS process doesn't always work perfectly, in the sense that there are some unmatched individuals at the end of the process, and usually some unmatched spots as well. So if you read the newspaper, there's a lot of discussion of the unmatched people, and there's usually less, although there's some discussion of the unmatched spots. And that's because physicians may want to train in a particular specialty, and they may not be selected into that specialty. So
it's also a competitive process to get into residencies, either the family medicine route, which is a specialty, or all of the other number of specialties that there are.
It is a very competitive process. Beyond residencies, a small but increasing number of physicians will do fellowships or other types of post-residency training. And then at the end of the residency, they would write exams of the Royal College of Physicians and Surgeons or of the College of Family Physicians.
And it's important to recognize that these are national certifying bodies, which is very distinctly different from colleges at the provincial territorial level, which are regulatory authorities, which are also different from colleges, which could be some training institutions, not for medicine, but for other healthcare professionals. So we use college for a number of different things, which is very confusing.
It is actually, that is one of the very confusing things, is the many, many definitions of the word college here.
The other thing that I want to ask, just to come back to that distinction that you made at the beginning about that health professions are in the public sector or private sector, we have a number of professions that train publicly in public institutions, whether that's provincially, territorially funded colleges and universities. So we invest as taxpayers into their training, and they invest in terms of their tuition and all of the time and energy that they put into their training. But then they are only accessible in the private sector, or to those of us who have private health insurance. And I'm just curious from an economic perspective, is that a good return on our public investment?
I mean, we train lots of people in public institutions. We train people in fine arts in public institutions. We train people in engineering in public institutions. And some of those engineers you're not going to have access to them. And you may not want to go and see a fine arts performance, or you may. I'm not sure that we should be thinking about the health sector or health professions any differently than we think about, engineering or, sociology or anything else at a public sector institution. The goal of the institution is to train people for careers and for life, not just careers post-graduation. And, once people graduate, they may decide to pursue the career they've been trained for, or they may not. They may decide to pursue something else. And that's always true in every single occupation. In fact, in the health professions, it's probably more true that people stick to their training than in many other professions. And if you look at engineering, which is another very expensive area to train people in, a very large number of engineers are not working in engineering 5 or 8 years after graduation.
I think that's fair, because I think some people raise that as, we invest and in their training, we should have access to them. So,
but then I'll give you another answer to it. I live in Ontario, and it's not clear to me how much taxpayers actually put into the education of most undergraduates or graduates in Ontario. Maybe undergraduates more. I mean, my view is that tuition is pretty close to the cost of education. I mean, universities do a lot more than education, and certainly tuition is only, say, 40-ish, 50-ish% of the total revenue of a university, but teaching is only perhaps 40, 50%, maybe 60% of what a university does. So it's not clear that the public subsidy to education is as large as all that.
All right, so let's get into the challenges facing the health workforce. We hear news story after news story about shortages of health workers. And Stephen Lewis, who's one of the members of our podcast team, has referred to this as the scarcity narrative. So many Canadians do not have access to the care they need or wait too long for an appointment. And there are reports of health workers that are burned out. So what's the root of this problem?
Yeah, so that's a good question, and I don't think anyone has a good answer. I'll give you a few thoughts on it, which may be insightful or may not be insightful, depending on
Okay.
your view of the world. We have more physicians and more nurses and more healthcare practitioners in almost all fields now than ever before. So
Okay.
the example I like to give is there was something called the Barrow-Stoddart report a long time ago in the early 1990s, and it argued that we had way too many physicians. So if you compare us to the era they were writing about, which is like the late 1980s, like nice to call it 1987. So today we have about 35% more physicians per capita than we did in 1987 when we had a surplus, right? And so there's a something doesn't work here, right? There's some problem that we had a surplus in 1987 and we've increased our physician supply by 35% and now we have a shortage.
Mm-hmm.
And you can make an argument. In fact, I think there's some numbers that would back up this argument that say population aging basically consumes about half of the 35% increase in the physician labor supply. Or the other side of that is physicians are working a bit less than they used to. Now, the average physician today is still working around 40 hours a week, maybe slightly under, but rough ballpark 40 hours a week. But in 1987, the average physician was working something like 48 hours a week. That's a fairly substantial decline in labor supply by the typical physician.
So we have a supply and a demand issue, right?
Right.
So that's why when we have really problems when we use provider to patient ratios, it doesn't take into consideration that the population may be very different. It ages, then, people are more likely to be ill as they age. We have a larger population, and we have providers that are themselves also aging. So on the supply side, they may also be working differently. These are two possible routes to the problem. What's your third one?
Third one is the structure of Canadian Medicare. I think
Okay.
we have a particular challenge in Canada. So if anyone who's taken Economics 101, so if something is a good, that is to say you want it, you like it, and the price is zero, how much demand do people do? And effectively demand is infinite. So we have just increasing utilization within age categories. Even though the population is aging, if you look at 45-year-olds in 1987 versus 45-year-olds today, we see an increased utilization. And partly that's driven by the nature of our system where services are free at contact, free to the individual receiving the services. Of course, that's true at the level of the family practitioner. Once to get beyond the family practitioner, that's much less true. But
So
that
Arthur,
is
what to what extent though is that the case? We talk about the increasing complexity of health issues in our population. We talk about, our people are living longer. So
yep.
the demand is actually truly legitimate demand. You know, I think the
Some of
average
it is.
person just doesn't like say get up in the morning and go, "Oh, I've got nothing to do today. I think I'm going to hop over to my doctor's office," because it's just not the case. We know there's long wait times. We know that there's an opportunity cost to trekking down to the street to the doctor's place. So I don't think that the complete classical economics works here.
I 100% agree with you. And classical economics works in very few places, in my view. But that doesn't say that it doesn't have some small insights into it. So I agree 100% with what you said. The average person does not wake up in the morning saying that. But you don't need the average person to say that. You just need the extreme 1 or 2% of the population to think that. And you need the 1 or 2% of the population to say, I'm bored, I'm going to go to a physician's office. In Ontario, if you tabulate like visits per person, there are some people seeing a lot of family physicians. There are a small number of high cost users. And
Well, and
this
some of
system,
that may be maybe the patients
and some,
requesting that, and some of it might be generated by the different healthcare providers, right? So,
it's entirely possible.
mhm.
It's less likely to be generated by healthcare providers when you have excess demand.
Could you describe how we plan for the workforce presently and how we might do a better job than just muddling through?
So there is some planning that goes on in Canada, although there is very little Canadian planning. So what I mean
Okay.
by that is provinces do some planning, but there is very little national planning, and geographic mobility can undo a lot of provincial planning. And then international mobility, of course, can undo even national planning if there were such a creature. We do mostly planning on the physician and nurse labor supply sides. We don't do a great job of it. It's very hard to think about what the right thing to target is, what the right number to target is. And it's very hard to carry through. A lot of times planning is very affected by political cycles. My view is that the planning in Medicare is mostly about funding. The planning that the government really cares about is about expenditure management. It is also about service provision, but Medicare, Canadian style Medicare, is primarily about funding healthcare. Medicare is a funding system. Medicare is not a care delivery system. So we actually don't have a care delivery system in Canada. In fact, one of my good friends refers to it as a care delivery non-system. And what the government tries to worry about is the Medicare side of it, which is about health insurance. It's about paying for when you or I or someone else sees a physician or goes to the hospital, but it's not about planning for the services that they would provide. And so there have been some very interesting efforts to change that, or maybe I shouldn't say that. There have been some interesting proposals. I don't think they've made it all the way to efforts. Calling them efforts is too strong. So if you think about what Jane Philpott is proposing, for example, she's proposing
in Ontario,
something
in
that
terms
looks
of primary care.
Right.
Yeah.
She's proposing a primary care model that looks more like the Scandinavian countries or like the UK, where healthcare is provided the same way K-12 education is provided, where you have schools that have catchment areas in the same way you would have clinics that have catchment areas. Everyone in a catchment area can go to that school. Everyone in the catchment area can go to that clinic, at least for primary care. But Canada has never, ever done that.
But planning is about more than just what governments do and what governments pay for publicly. We could have a number of different interest holder organizations that contribute to planning. It would be an activity that's done on a more cyclical basis. I mean, if we think about, for example, other sectors, the construction sector, they do more planning there to ensure that they have enough jobs. And that, constitutes less of Canada's GDP than the health workforce. What planning, what might be sort of better practices in planning than what we are doing presently?
And what are some international examples that we should be thinking about or emulating?
Let me go with the workforce in construction. I think in some ways it is a bit easier because in the private sector, there is no single payer. There is no changes in the flow of funding at the whim of a government. Like there is a marketplace. It is much easier to do planning in the situation where there's a marketplace than it is.
But wait a second. The way in which you're describing it is that there's a supply. Well, the supply of physicians and nurses is fairly fixed.
Yep.
Right.
From year to year, it is. Some people would say the supply of physicians and nurses from year to year is fairly fixed, which is true. But the training period in healthcare is so long that you need long-term planning in a way that doesn't happen in, for example, construction. So you can train a welder in 2 or 3 years, but a physician takes at least 9 and sometimes 10 or 11 or 12 years to train. Even though you can't change the number of physicians very quickly, because the training, if you look at the amount of time to change the number of physicians relative to the length of training, then that's much more similar to other sectors, where you can change numbers more quickly, but the training period is much shorter.
For planning on an ongoing basis?
It does. I am a big fan of planning on an ongoing basis. I'm saying in some sense what is as opposed to what ought.
Yeah.
What the way we do it as opposed to the way we should do it. We should be doing planning. In my view, actually, planning should be boring. It should be the kind of thing that people in the back room of the Ministry of Health are doing. And some of the people in the back room, they've been doing it, and this is their 27th year doing it. They know how to do it. They've done it many times. And other people in the same office are in their 3rd year, and they're just learning how to do it. It should be that there are teams with experienced people bringing in new people, and that we grow some real skills, develop some real data that supports the implementation of training. We don't do that for the most part. Like there are some efforts. The Ontario Ministry of Health, where I live, makes an effort in this direction, but the efforts are, quite frankly, modest. And well, look at what Health Canada did. They did a big exercise recently, but
Caring
it
for
was
Canadians report.
right. Nobody on that team had ever done it before. Everyone was doing it for the first time. And as far as I know, the team has disbanded and there's no plans to do it again. There's nobody doing it for the third or fourth or fifth time and getting it right, improving on what they did last time. We need the federal government and the provinces to cooperate, to think about planning in a much more systematic and experiential way. Like we need to do a first report, get feedback from various interest groups, and then do a second report, get more feedback, see how it plays out, do revisions. It needs to be much more systematized, much more regularized, and we don't do that. We muddle through. Again, the phrase is not what we should be doing. I think it's what we do.
Well, maybe we need to also talk about this on the service level, because within a hospital, definitely there's planning of the number of nurses per ward, per patient. And within primary care, within the teams, the contractual agreements are based on the patient population within a practice, and you're allowed to have 5,000 patients, you're allowed to have 0.5 of a social worker. So those pretty much do exist, although there's often exceptions to the rule. So there is discussion when we talk more, I guess, sectorally or within different services, that's applied perhaps inappropriately.
So those definitely happen at local levels. There's those types of things. There's also in some collective agreements, there are very explicit ratios. So in collective agreements in long-term care homes, there might be ratios about the number of nurses per bed or per resident. Although not all collective agreements have those types of things for sure either.
But that undermines potentially the ability, and we talk a lot as part of this podcast around planning and how you lay out what you expect from a service. You allow them to develop their services as needed for the community and their patient population, and then we measure them on outcomes. But being that specific around how they mix and match different professionals within their practice or within their services, perhaps undermines their ability to innovate or to reflect the local community or the needs of the patients.
Okay, so there's a bunch of stuff in there. So I would agree with you. Ratios are not the way we should go. In an ideal world, a better world, maybe not ideal, better. I don't actually claim to know what ideal looks like, but better world. We would look not at the number of service providers per patient, but the number of services per patient. And we don't care as long as a hospital does a certain number of a range of services, we don't care what mix of professionals provide that, because we know that health professionals have overlapping scopes of practice. And so one hospital may choose to deliver a service using one mix of practitioners, and another hospital may choose to provide the same service with a different mix of practitioners. So we should be thinking maybe about services, but we don't.
I think also on the issue of scope of practice, too often we think of scope of practice as a checklist in terms of what the regulatory body says you can do when we're thinking about deploying the workforce.
If you talk to pediatricians, for example, they will talk about increasing acuity among the people that they see because we are so successful at keeping people alive that the patients that they are seeing are changing and the acuity of the patients that they see are increasing. So there are some big changes because of technology. Just as sort of a background to this, I think we alluded to it earlier. So if you look until I'm going to say 30 years ago, you guys can cut the line someplace else. Most of the increase in life expectancy happened because of infant mortality decreases and what was happening in early life. But in the last 20 or 30 years, almost all the increase in life expectancy has been beyond age 65. That also changes very much the nature of the care we need to deliver to our society, right? Because we are not only have an older population, but that older population has higher acuity, higher care needs, and is living longer. And we are being very, very successful as a society in keeping people alive.
Well, and that affects the demand side that we talk about to keep in mind for planning. But there's also all of these other healthcare practitioners that could contribute, whether in a team or individually. We hear of announcements every now and then for we're expanding the scope of pharmacists to be able to do X, Y, and Z, or nurses are able to prescribe. And that's often framed in a very uni-professional way rather than here are the services that need to be provided. Let's optimize everybody's scope of practice across the different members of the team.
Yeah, so I'm not quite sure how to square that circle, as it were. So in some ways, what you announced at the beginning, pharmacists are being given increasing ability to not only prescribe, but to prescribe and to treat certain types of things. That is a change in scope of practice that is going to change the composition of teams. In medicine, we're always going to need to draw lines about or boundaries around who can do what, who has the skills and the training to do what. So when you say that pharmacists have increased ability, for example, in Ontario, they can now treat pink eye, for example. But my understanding is for many of the things pharmacists treat like that, they need to have particular training to do it as well. So the legislation says that pharmacists, if they receive particular training, then they can do a particular task. So their scope of practice is increasing, but the training requirements are simultaneously increasing. So that adds complexity to what you were talking about, because it's about ongoing, continuing training together with ongoing, evolving scopes of practice.
And sometimes the training is ahead of necessarily what the regulated scopes of practice are, but that's not necessarily for all the practitioners who are out working, but it could be for like the new graduates that they have that training.
Definitely true. Definitely true.
Okay, so this is much more complex. And so our podcast is focused on not just focusing on the challenges, but what are some of the key solutions? So we give our guests a magic wand to identify some key policy changes. And you could do as many things as you want with your magic wand. So what would you do?
So that's a good question. So I think the main thing I would do would be to increase the bravery level of the system organizers, which includes politicians. I think if we're going to have change, if we're going to actually have a healthcare system, as opposed to a health payment system, there are a lot of vested interests. There's a lot of people who are scared, including me, and we need some very brave people. So the first thing I would do would be to notch up people's bravery, because it is not going to be easy to do something like this. And we're going to need
they need to do
to build a healthcare delivery system, to actually systematize healthcare delivery so that it's organized, it involves planning, and it involves the efficient delivery of care. So you can think of the type of stuff Jane Philpott is pointing to as being a step in that direction in a particular area. She's only thinking about primary care. She's primarily thinking about physicians. Those types of initiatives where you actually build a system could help us a lot. And then you need to have a planning process. This is going to be even a further step in bravery, a planning process that's longer than the political cycle. Because there's an old joke in Ontario. The old government was talking about 100 nurses a day, and the new government is talking about 100 nurses a day, but they were talking about hiring, and now they're talking about firing, right? The problem is that the healthcare system planning and funding can change on a dime when the government changes. You need a planning system that's longer than government mandates, and that is really hard.
Would you open spaces in the various colleges and medical schools and nursing schools? Would you open more spaces for training?
Another alternative is just rank up the supply. And there might be some unemployed physicians, nurses, midwives, others, but just ramp up the training.
Well, there would never be unemployed physicians as long as they can provide office services, because when you have a billing number, all you need to do is provide office services and you can make money. I mean, you may not have access if you're a surgeon to an OR. Right now, in fact, in many areas, the issue is not human resource constraints, but physical resource constraints. There aren't enough OR hours. There isn't enough equipment, etc. So would I increase supply? The answer is yes, but only if you're willing to pay more taxes. Because at the end of the day, I don't want to charge my healthcare to my children, and that's what we're doing right now. So if we want better healthcare, we need to be willing to pay for it today. Are you willing to pay more taxes? And if the answer is yes, then yes, we should have more positions in medical school and nursing school, etc.
How do you depoliticize the planning process?
I don't think it's possible to depoliticize it with politics with a small p. I mean, politics is like breathing, right? Politics is everyone is a politician. What I'm saying is that it needs to be, we cannot have large changes in policy when we have changes in government. We cannot have a reorganization of a healthcare system when there's a change in government. It is just too destabilizing. So we need to have planning horizons that are longer than the length of government. That's not to say it's not political. It's political in the sense that our conversation is political. You and I undoubtedly disagree about things, and those are political, ideological disagreements. I don't know if we do actually. Maybe we don't, but maybe we do. We probably do. We need to have planning horizons that are longer than government so that things can actually be planned and implemented without halfway through an implementation, someone saying, oh, we're going to stop doing this and we're going to do something completely different.
But why do other governments and other countries manage to plan, manage to have lower per capita expenditure on healthcare, manage to have a much less demoralized workforce than Canada, have better outcomes? Why do other countries perform better?
So it's a good question. So what other countries are doing better than us? Like, is the UK doing better than us? Is the National Health Service better than us? I'm not convinced. Maybe, maybe not. It's a little bit cheaper. And there's a difference here. So Bob Evans wrote a paper, maybe I think with other people a long time ago, about minding your P's and Q's. P's and Q's, he meant prices and quantities. Right. So in Canada, one of our issues is that prices are high. And part of that is because we live next door to the US. So if you look at the prices, say wages or the cost of a physician, the cost of a nurse in France or in Scandinavia compared to Canada, our prices are quite high. Not as high as the US, almost as high as the US, but not as high as the US. Same on pharmaceuticals. We are one of the highest cost countries for pharmaceuticals in the world. So our problem is that our bill is high, not because Q, quantity, is high, but because P, price, is high. There is no good solution to that. We live next door to the United States, which is a very high price country. And it is, if we were further away and if we spoke a different language, say we were in Sweden and we spoke Swedish, it would be a lot easier to have lower prices.
What does the Canadian public need to know, and what can they do in regards to, some of your magic wand solutions to push forward maybe this much more systematic approach to planning and service delivery?
To begin with, I don't think the Canadian public speaks with one voice on this. As divided as the politicians are, I think the politicians accurately reflect the Canadian public, right? In the sense that,
how do we get the Canadian public to the point of agreeing to that it seems logical for us to be planning? That's
a good question. Some Canadians will never agree to that. I mean, we live in a democracy, which means that we agree to disagree with each other. And so we have to realize that there are a lot of people out there with very strong opinions and different opinions, and that's reflected in our politicians, but the politicians are just a reflection of the population. So I don't think it's possible to get the Canadian population as a whole to agree. What we need to have is a sufficient number of people who think that planning should be boring and should happen in a very stable, steady, sort of productive way. And we don't need everyone to agree. We just need enough people to agree. And then we need to build up a community of practitioners that have skills to actually do it. Because this is not about, people being pulled in off the street with no skills doing planning. There are real skills here. And then there has to be like a data infrastructure. There has to be plant and equipment. There have to be computers. There have to be, etc. You need a lot of data collection. So I think we need to build up that human and physical infrastructure to do planning. And we need people to understand that it's valuable. We don't need everybody. I think it's impossible to talk about the Canadian population as a whole and think that we're going to bring everybody along. We need to bring enough people along that it happens. I think once people see the outcomes, once you have 5 or 8 or 10, and it's going to take 5 or 8 or 10 years of good planning, then you will start to see improvements, and I think people will be sold by the improvements that they see.
Thank you so much, Arthur. I really appreciate having you here on our Health Policy Off Script. And back to you, Matt.
Thank you for listening to Health Policy Off Script.